Okay.
Good evening, everyone. I'm Dr. Cribier. I'm a cardiothoracic surgeon in Apollo Hospital, Chennai. Today I'm here with Dr. Vivek Gupta, who's a cardiologist from Apollo Hospital, Delhi. Welcome.
Okay, so it's very interesting, and today we are having a conference of Cribier valves, which has been initiated by Dr. Gopal and Dr. Associate, Dr. Chandra and many others. I'm Professor Dr. Vivek Gupta, Delhi Apollo Hospital. I'm very happy to be speaking with Tejal Joshi, who is also part of I'm working in Apollo Hospital. She is working as a cardiac surgeon, so it's a very hard field. When we talk of TAVI, it's the Transcatheter Aortic Valve Dilation. From the beginning, it has been told that it is a heart-in approach which helps the patient coming out of opening of the aortic valve. So let me tell you, Tejal, that aortic valve disease is a degenerative aortic valve disease. I interest in physicians also. I would like to go from basic to advanced. Aortic valve disease, which is a aortic stenosis, which is degenerative aortic valve disease, where the valve area goes down, when you echo the aortic valve is measured by echo, goes to a singular E level, and the heart has to contract against its released aortic valve. This causes a lot of dysfunction, and over a period of years it can lead to heart failure and symptom of syncope and cardiac arrest because of arrhythmias. One of the leading cause of cardiac mortality, especially in elderly patients. Professor Alain Cribier, who was my mentor, and I worked with him in 1996-98, he was a pioneer in treating aortic valve disease. He was a very important interventional cardiologist, and in 1985, he did the first aortic valvuloplasty. A lot of people will not know. 1985, at that time, aortic valvuloplasty was being done, but aortic valvuloplasty probably was a bit touch because you are putting a balloon in the aortic valve. When you inflate, there will be a fall in blood pressure. And therefore, it was considered to be one of the dangerous. He did first time in 1985, and then Cribier from France, Charlotte Hospital. And then overnight he became a hero, and Dr. Doctors from Europe and USA came to learn the technique. Because it had two challenges. First of all, to cause a severely aortic stenosis valve, and then putting a balloon and then inflating it and then deflating it quickly, otherwise the patient could have died in the game. So he had the courage to do it, and this was published in Lancet at that time, and also in Implant and Alain. In 1985, this technique of balloon aortic valvuloplasty became a little not so commonly practiced because this had a lot of recurrence. There was a restenosis over a period of few months. From 1985 to 1996, he was thinking how to help it out because surgical aortic valve replacement, which is alternative to TAVI, was considered to be much more risky, and especially in elderly patients. And aortic valve stenosis is degenerative, is a disease of elderly patients, and most of the time the patients have a low ejection fraction. They have a comorbidity of post bypass surgery, sometimes nephropathy, lung disease, COPD. I'm talking about the patient above 80-85. These patients were left with only medical treatment, they used to die. Dr. Alain Cribier had a passion, or rather he was obsessed with the idea that what can be done non-surgically. So he developed a valve, which was a biparasitic valve on a stent frame. Biparasitic valve on a stent frame. And then he did a lot of experimentation. When I was working in 96 to 98, he did a lot of experiments on the big model in Paris. He was in Rouen, I was in Rouen. And that time, finally, he did the first case. Doing the first case is always important. You have to be innovative. You have a lot of support from the companies, and then the idea. It's not easy. Doing the first case is always a challenge. He did the first case April 16, 2002. Almost 22 years now. This 2024. And that he again became a hero because overnight everybody from Martin Lyon, ECT, and European countries that they saw was live, and patient was a 57-year-old. Let me tell you the first patient. A lot of people will not know. The first patient was a 57-year-old post bypass surgery, cardiogenic shock, refused by surgeons, and he was almost dying. And he had the courage to do this. You might be knowing. He had the courage to do this patient with a. That time he did a transcatheter. It was through the femoral vein, not the femoral artery. From femoral vein, going from the right atrium to left atrium, left ventricle, aorta, and putting the valve. So this was the technique he used at that time, and he, of course, this device then further it was in a lot of European countries, especially UK, and then the Cribier from Germany, and then American people, they started doing this. So that procedure became very friendly, and then the transfemoral technique became from retrograde to antegrade, and now it's very popular. So I would tell you that this technique is a revolutionary technique. From 2002 to 2024, more than 6 billion patients have been treated all over the world. This is a patient-friendly technique. Now surgical aortic valve replacement, earlier it was only for the high-risk patient. Now it is for low-risk patients, even young patients can be done. Now we have two types of valve. One is balloon expandable, which is Edward valve, and many other my valve from India. And also there are many others who are balloon expandable. And there are self-expandable valve, which is Medtronic Resolute, and Medtronic Evolute, which is a self-expanding technology, and many others like Boston Scientific. So as of now, this technique is replacing the surgical aortic valve replacement. I'm happy for the post directors of this valve, India valve, that they have done a lot of teaching and we learned a lot of things. And later you will be doing, even cardiac surgeons are now preferring to do a TAVI rather than surgical aortic valve replacement. Thank you very much.
Thank you.
So what is
नीचे से बंद करिए and